Claire. So our next speaker is Dr. Terry McVeigh, and Terry is a consultant clinical geneticist in the Royal Marsden NHS Foundation Trust, specialising in cancer genetics. Terry undertook undergraduate medical training in clinical genetics in Ireland and then went to Yale, Royal Marsden and Brisbane for further training. She's a PhD from NUI Galway for her work investigating the translational applications of genomic profiling in breast cancer. She developed and curates a patient information website called cancergenetics.ie, and she's the most amazing pair of shoes I've ever seen in the history of the world, and you get to see them in full colour up here in a while. And Terry's talk today is titled Genetic Basis of Ovarian Cancer, Implications for Treatment, Follow-up, and for the wider family. So Terry, you're very welcome.
Looking at your shoes now, Terry.
Thanks everybody, so good morning. Thanks very much to the OvaCare team for inviting me over. I'm delighted to have an excuse to come back to Ireland every now and again. So I'm a medical doctor, but I specialise in the care of people that are either affected by cancer or at risk of cancer, and we'll go through some of the genetic basis, particularly of ovarian cancer today. So I suppose we talk about our genetics all the time, but it's a bit of an abstract kind of thing because it's not like you can pick up a gene or look at a gene. I always think about our genetics like being an instruction manual that tells your body how to grow and develop. And when I look at genes, this is how they look. They look like a big string of letters, okay? And what I'm looking for when I do genetic testing is I'm looking to see is there a spelling mistake. So is one of those letters being swapped for another letter, or has it been deleted out? Because that completely changes the message that your body gets. And when we're looking for mutation, which is a word I hate, so I tend to use the word alteration or variant, because mutation just makes me think of X-Men, you know. So I don't really like it, but that's what people call it occasionally. But I think about it like being a spelling mistake. So that's what we're looking for, basically. Now, genes, by their very nature, are inherited. So as Rachel said earlier, you get 50% of your information from your mum and 50% from your dad. So your dad will give you one copy and mum will give you your other copy. So if you've got an inherited mutation on one of those genes, then it's a 50-50 chance of inheriting that as well. But all cancer is genetic, actually. Now, not all of it is inherited, but cancer all starts because of a genetic problem. Most of these are acquired, and if they're acquired over time in the cancer cell, they can't be passed on. Basically what happens is a normal cell going happily about its business for some reason develops a mutation and then acquires more and more of these kind of mutations and over time becomes cancerous. So that's how the vast majority of cancer happens, but there will be a small proportion of people that are born with inherited mutations that predispose them to cancer, and those mutations that are inherited can also then be passed on to the next generation. So this is basically what happens. Like, by virtue of being alive, your cells are getting damaged all the time, and if you happen to get damage in the wrong gene, you then develop cancer. But if you're born with an inherited mutation, that's present in all your cells and it's there all throughout your lifetime. So again, when we're inheriting our genes from our mum, if mum carries a BRCA mutation, for example, you have a 50-50 chance of inheriting that from her. So we have to think of genetics in two different ways when we're thinking about cancer. We think about the ones that are inherited, which are present in all of the cells in your body, but there will be genetic changes that are just restricted to the cancer cells themselves as well. So that's what I mean about all cancer being genetic, but not all of it is inherited. You can test for inherited genetic changes by doing a blood test, which is the test that Rachel described earlier on. But if we're looking for genetic changes in the tumour, you might have a tumour biopsy to look for changes in the cancer cells themselves. So let's get into the nitty-gritty now of why we're here today. We'll talk about ovarian cancer specifically. So all of you will know that ovarian cancer is just a descriptive term that actually describes many different types of ovarian cancer. It can be broadly divided into epithelial and non-epithelial, and there's loads of different subtypes within that. So I won't be able to go into all of them today, but I'll focus on the ones that are more likely to be inherited than not. So the ones we'll talk about predominantly today are high-grade serous, clear cell and endometrioid. The non-epithelial I'm not going to go into in too much detail because they're quite rare, but those ones can also have inherited risk factors as well. This is the kind of breakdown of the inherited risk factors that we talk about. So BRCA1 and BRCA2, I think are, nearly everybody has heard of them at this stage. But there's a smaller proportion that are accounted for by these things called the mismatch repair genes, and alterations in one of those genes will give you a condition called Lynch syndrome. And I'm delighted to see Lynch syndrome Ireland here today, because I think that gets a little bit ignored sometimes when you're talking about ovarian cancer, so I'll talk about that in a little bit more detail later on. And then there are other less common inherited risk factors that can influence your risk a bit, but nowhere near as high risk as Lynch syndrome or as the BRCA genes. And they're where a lot of research is focused at the minute, because we're not really sure when or in whom we should be offering testing for those particular genes. But you'll see there's a huge chunk that we just don't know yet, and that's why we need to keep researching, and that's why there's people like me that will hopefully still have a job for a little while, because that's what we need to figure out. These are the kind of, if you look at it in a slightly different way, you can see what I mean about the risks associated with these genetic alterations. So BRCA1 gene alterations, for example, if you've got an inherited alteration in BRCA1, your risk of ovarian cancer is between about 40 and 60% over the course of your lifetime. So Rachel did the exact correct thing to do and do the preventative surgery, because you can't live with that level of risk. BRCA2 is a bit lower in terms of risk, but not negligible by any stretch of the imagination, so about 10 to 30% over the course of your lifetime. And the Lynch, the genes associated with Lynch syndrome alterations in those genes will give you a risk of between 10 and 17%, depending on what gene you're talking about. They're very high when you think about the average woman on the street, and her risk is about 1.5%. So having a genetic alteration really influences your risk quite significantly. There's a whole heap of other common things here as well in the grey. Each of these individually might influence your risk by 0.1%, 0.2%, big deal. You're not going to offer testing for those individual things. But what we're working on is trying to figure out if we can test for all of these things. Is there some way we can figure out, if you have 10, 20, 30 of these, what does my risk become then? So there's a lot of work happening there. So let's focus on BRCA1 and BRCA2 for a second. The likelihood that your ovarian cancer is caused by an inherited risk or an inherited alteration in BRCA1 or BRCA2 really depends on the subtype of ovarian cancer that you've got. If you've got a high-grade serous type of ovarian cancer, there's a 1 in 5 chance that you do have an inherited BRCA alteration. So everybody with high-grade serous ovarian cancer should be offered a blood test for BRCA mutations. If you've got endometrioid or clear cell, the risk is lower but not insignificant. So again, we should be offering testing to those people. If you've got something like mucinous or low-grade serous, the likelihood that it's due to a BRCA mutation is much, much lower. So we don't tend to offer testing to those people as much unless there's a suspicious family history. So let's think about the cancer risks that are associated with BRCA1 and BRCA2. So the name kind of annoys me sometimes, actually, because the BRCA stands for breast cancer susceptibility gene 1 and breast cancer susceptibility gene 2. Obviously, the fact that we're talking about it at an OvaCare day, ovarian cancer is a big part of it as well. But also, there's a slightly increased risk of things like pancreatic cancer and melanoma skin cancer. And in men, there's a risk of male breast cancer and prostate cancer as well. So it's really a multi-organ condition. And we need to be mindful of that. And, Angelina Jolie, in fairness, has done wonders in making people aware of the Ovarian Cancer Association, so we can't forget about it. These are the risks, again, just to demonstrate graphically. So you can see on the blue line there is the average risk in the background population. So the risk, as I said, approaches about 1.5% over the course of your lifetime, but generally it tends to be a disease of older age. In somebody with a BRCA1 or a BRCA2 gene alteration, the risk is much higher and it also starts much younger. So the risk really starts to ramp up from about the age of 35. And that's why people like Rachel need to go through this risk-reducing ovarian surgery at a much younger age than you would have your natural menopause to try and get ahead of that increasing risk. So what happens if we do identify an inherited BRCA variant then? Well, there's treatment implications, and I know Donal is going to speak to this in a bit more detail. Really what it influences is the kind of systemic treatment that they would give to you. So if you've got a BRCA-related ovarian cancer, you're much more likely actually to respond to things like platinum-based chemotherapy and to new targeted agents called PARP inhibitors. And bizarrely, actually, people that have BRCA-associated ovarian cancer do a little bit better than people that don't have a BRCA gene alteration, so there is a silver lining if you have to think about it like that. It also has implications, though, for future cancer risks, and this is for both the patient and for their blood relatives. So we've already talked about the kind of different cancers that you can get with this. So it's very important to find if somebody does have a BRCA gene alteration, because it doesn't just mean things for them, it means things for their children, for their brothers and sisters, for their cousins, their aunts, uncles. It doesn't just stop with the person you're testing. This, and Rachel described this really nicely, this is very much what you tend to see in families with inherited BRCA alterations. So you tend to see lots of people affected by cancer of different types, including breast and ovarian. Testing in the family is always a little bit tricky because I think for a long time we've sort of been nervous about talking to people about genetic testing. When you've been diagnosed with cancer, obviously you've got a lot on your plate, you know, when your focus is getting through your cancer and having your treatment. Now that there are treatment implications with the genetic test result, I think we're getting better at offering people genetic testing, but for a long time it was sort of forgotten about. It was like, we'll wait till Mary's better and then we'll ask her. Whereas actually you need to start asking about it sooner. It's better to start in the affected person, because I think for ages we were like, we won't bother Mary, but we'll tell her sister to come in for testing, and actually that's wrong. The reason we want to start with Mary that's been diagnosed with ovarian cancer, if we find that she has a BRCA1 alteration, we can then offer testing to her siblings. And you can find then this woman who's positive, we know that she's at risk of ovarian cancer, but this woman that's negative, she's not at risk, and she can be reassured and go about her business without the same anxiety that she would have if she was positive. If Mary decides not to have testing, or if she's not available, or if she's not offered testing, which is often what happens, if her sister comes in to have a BRCA test, her test might be normal, but actually that's not informative for me, because I can't reassure this woman. Because all I can say is, okay, we haven't found a BRCA gene alteration. I don't know, is that because the ovarian cancer in your family is because of something else? Or is it that because there's a BRCA mutation in your family that you haven't inherited? So what I say to this girl that's had her normal test, I'm like, well, okay, you have a normal test, but actually I would still take out your ovaries. And what has happened there is that I just haven't tested the right person, so this person might end up having an unnecessary operation. So it's very important to be able to find the BRCA mutation in the family, so you need to test the right person. So how can you get BRCA testing in Ireland? This, as Rachel said, is very, very tricky at the minute, because there aren't many geneticists floating around in Ireland. There are certain people that can access testing through their own oncologists, so make sure you ask. If you're going through ovarian cancer treatment at the minute, make sure you do ask the question, because they may just not have thought of it. But there are only certain people that are eligible for testing in that way, so it's not a done deal, but do ask about it. If you do need to go through clinical genetic services, there are public services in James's and in Crumlin, and there are private services in the Mater, Blackrock Clinic and the Hermitage. So there are services around, you will be waiting, is the only thing. There is a tumour BRCA testing study as well. So do you remember I said earlier that there are mutations that can happen just in the tumour as well? Those people will benefit from the same kind of treatments that the people with the inherited alterations will, so it's very important that we pick those people up as well. And again, this is being rolled out through the oncology clinics as well, so this is really useful. So what do you do if you have a BRCA, an inherited BRCA alteration? Now Rachel has described this very nicely, done my work for me, thank you. So, a couple of different things. I'm going to pretty much ignore men today, very sorry to all the gentlemen in the audience, but we'll talk about the women for now. In terms of ovarian cancer, and again Rachel has said the difficulties with this, screening for ovarian cancer just isn't actually safe to do because we don't have a good enough test. There's been a lot of large studies, and one of the big ones is the UK Familial Ovarian Cancer Susceptibility Study, and what they looked at was a blood marker called CA125. So CA125 is this protein that's secreted by ovarian cancer cells. It's really helpful if you have ovarian cancer, because generally when you have ovarian cancer, your CA125 is really high. Give chemotherapy, it comes down really nicely, and you can track and see if people are starting to relapse. But not everybody that has ovarian cancer has a high CA125, so you might have a plumb normal result, and that can be falsely reassuring. When they looked at this in this study, they looked at the CA125 in combination with the transvaginal ultrasound. And they also took into account things like the BRCA status, the age of the person, whether they've gone through the menopause or not. The way the paper is written is a little bit misleading, because it's like, this is brilliant, we pick things up earlier. And they did, but the earlier was, instead of stage 4, it was stage 3. That doesn't actually change what chemotherapy you give, doesn't necessarily change how people do overall. What we want is to get a screening test that will pick it up when it's stage 0 or stage 1 at the latest, so we're still working on that. At the minute, we don't think screening is safe enough to recommend, so the only proven way is to undergo the risk-reducing surgery. Risk-reducing surgery basically involves, as Rachel said earlier, removing the ovaries and the fallopian tubes. We generally don't remove the womb because the risk of womb cancer isn't increased with BRCA gene alterations. It is with Lynch syndrome, but not with BRCA. So generally we don't remove it, really, because it's a much easier operation if you can just take out the tubes and the ovaries. It's usually done keyhole, usually in and out the same day. That sounds very straightforward, but obviously Rachel has described that it's not. The big pros of this, obviously, reduces your risk of ovarian cancer very significantly by about 96%. You won't remove your risk completely, because when we say ovarian cancer, what we actually mean is cancer of the ovaries, the fallopian tubes, or the lining inside the abdomen called the peritoneum. And the peritoneum, unfortunately, you can't really get it out that easily, so there is always going to be a tiny risk of primary peritoneal cancer, but that's in the order of about 4%. So certainly this is a very powerful operation. It also, if you've got a BRCA2 mutation, reduces your risk of breast cancer by about half if you have it premenopausally. BRCA1 is slightly different because those cancers tend not to be estrogen driven, so you don't get the same benefit there. The cons, obviously, Rachel went through this very eloquently earlier on. You're immediately thrown into the menopause, and obviously you can't have any more children. Early menopause, Rachel very nicely described the symptoms that go with it. So things like, that brain fog is very common, mood swings very common, hot flushes. It's not an easy ride by any stretch of the imagination. But there's also health consequences. So we're supposed to produce estrogen naturally until we're about 50. And that's beneficial from the point of view of your bone health, your heart health, your brain. And if you have an earlier menopause, you do have a slightly increased risk of things like heart disease, osteoporosis and reduced bone density, and cognitive decline as well. So that's why we don't do it in very young people. So we tend not to recommend it before the age of 35, unless there's a very strong family history of very early onset ovarian. Usually we recommend it after the age of 40 actually, because the risk between the ages of 35 and 40 is still quite small. Hormone replacement therapy actually is recommended, and it is safe in BRCA carriers even before the mastectomies. And I think people are nervous about that, understandably, because HRT has this negative connotation of being associated with an increased breast cancer risk. In BRCA carriers, particularly BRCA1, where there isn't this estrogenic drive, it is safe, and we do recommend it up until the time of your menopause. We don't want you to go, beyond that. The only people that's not safe in are people that have had estrogen-driven breast cancer previously, so you need to be a bit more careful in those people. This is an interesting study that's going on in the UK at the minute, called Protector. So this is a two-stage approach. So what they do with these women is they take out their fallopian tubes first. The reason for that is that we think a lot of ovarian cancer actually starts in the fallopian tube. So we're hoping that if we can do this early removal of the fallopian tubes and then go back when a woman is closer to her menopause to reduce her ovaries, we're hopeful that that would be a safe approach and it might offset the negative side effects of the menopause. We're not sure yet, so this isn't recommended outside of a clinical trial, but we're waiting with bated breath really to see if this is a safe approach in our women. Now, to talk briefly about breast cancer, so obviously there's a significantly increased risk of breast cancer associated with these alterations as well. And as Rachel said, the choices really boil down to either having risk-reducing surgery with double mastectomies or ongoing annual surveillance every year. For BRCA2 carriers, you can take these anti-estrogen kind of medications, but as we've heard already, they have quite nasty side effects, so they're not for everybody, but they are an option. Risk-reducing surgery is definitely something to consider as well. Very, very personal decision. Some people do have it, some people don't. And the benefit of surveillance compared to surgery, they're essentially equivalent. So surgery seems to be, touted as the only option. It's not. It's an option, and it's certainly a reasonable one, but it's not the only one. And the benefit of it really depends on the person's age, with younger women getting more of a benefit from survival overall. It also depends on whether or not you've had a previous cancer history, and this is particularly relevant to people that have had ovarian cancer, and also if you've had previous risk-reducing surgery. So what about risk-reducing mastectomy after ovarian cancer? We have to be practical about it. Your biggest risk is the ovarian cancer you've already had, so we need to be sensible about it. It's not a definite no, so we tend to say let's hold fire and wait and see how you do from your ovarian cancer point of view, and in the Marsden we consider it if somebody is more than 2 years disease-free. But again, your overall survival really depends on what age you are, the stage of your ovarian cancer diagnosis, and also the age you are when you're having your risk-reducing breast surgery. So, if you're 80, we'd probably try and put you off, to be honest. So Lynch syndrome then, let's talk about this briefly. So Lynch syndrome years ago was called hereditary non-polyposis colorectal cancer syndrome, and thank God they changed the name because it's a bit of a mouthful. But also it's a bit misleading because it's not just colorectal cancers that happen in this condition. There's a whole plethora of different cancers that you can get, including cancer of the ovary. It's approximated that about 2 to 3% of ovarian cancer is actually caused by Lynch syndrome. Most of the types of cancers that you get in this condition are endometrioid and clear cell, but you can get it as well with other types, including mucinous. The ovarian cancer that happens in Lynch syndrome tends to happen at earlier ages, so generally premenopausally. But the good news is that it tends to be earlier compared to people that don't have Lynch syndrome, and they do have better outcomes than people that don't have Lynch syndrome as well when you compare stage-matched people. Lynch syndrome is due to inherited alterations in a number of different genes that all belong to this family of genes called the mismatch repair genes that work to correct cell damage. The risk of ovarian cancer really depends on which of the genes is involved in the person's family. So the biggest risk is when people have an inherited alteration in a gene called MSH2, where the risk approaches about 17%. It's lower for MLH1 and MSH6, and people that have Lynch syndrome due to PMS2, there actually isn't thought to be an increased risk of ovarian cancer. So you really have to tailor your advice to people depending on the specific genetic alteration in their family. Testing for Lynch syndrome is a lot easier actually than some other genetic conditions. So you can start by testing the tumour. So this, when we're waiting a week to see a geneticist, or when we're waiting months to see a geneticist, you can do this test in about 5 days. So it's definitely quicker. Basically, you check to see if the proteins that are supposed to be made by these genes are working correctly in the tumour. And if you've got a problem with the protein, it suggests a problem with the gene, and that's when you move to doing your genetic testing on your blood. At the minute, testing of ovarian cancers for Lynch syndrome isn't done routinely, but it can easily be requested and should be considered in people with endometrioid or clear cell cancers in particular, and definitely if they've got a personal or a family history of other Lynch syndrome related conditions like bowel cancer, cancer of the womb, or indeed cancer of the ovary. We've started doing this type of testing in ovarian cancer pretty routinely in the Marsden now. So we started in the middle of 2016, and in that 18-month period we've tested 66 patients, 10 of whom we found abnormalities at the protein level, so they needed to go on and have genetic testing, and we found 3 of those patients that had Lynch syndrome. So that's just by doing unselected for family history, unselected for age, we found 5% of people had Lynch syndrome. So that's not an insignificant amount, and that's quite an easy test to do. So we do that routinely now for everybody. To briefly describe other inherited risk factors, so you'll have the eagle-eyed among you would have seen that I highlighted a couple of genes there, including BRIC1, RAD51C and RAD51D. Inherited alterations in these are incredibly rare and they're not tested for very frequently. The reason for that is that alterations in these genes increase your risk to a degree, but in a family where there's lots of ovarian cancer, it probably doesn't answer the whole question. And we don't offer testing routinely, really, because the utility of testing in relatives is uncertain, because even if you don't have the inherited alteration that your affected family member does have, you might still have an increased risk of ovarian cancer because of other inherited risk factors that we haven't identified. So we're still trying to figure out where we should be offering these testing and what we do with their relatives, because actually it probably isn't the whole story. There are other low-risk things, so these are called SNPs for short, which stands for single nucleotide polymorphisms, and they're basically just spelling mistakes, essentially, that we were talking about earlier on. There's about 40 of them have been identified that can influence ovarian cancer risk. Now, each of these on their own increases your risk by a tiny amount. So testing for each of them independently is pointless because it's not going to change management. But we think that there's a combined risk there that might actually be significant. It's not as simple as 1 + 1 + 1 is whatever that is. I can't remember how many ones I said there, but it's not an additive thing. They do kind of interact, and so we need to come up with some clever person needs to develop an algorithm so that we can actually give a proper risk associated with these. So testing of these in clinical practice isn't available anywhere. It's not just an Irish thing. This isn't being done anywhere at the minute. These are the list if you're interested. I don't expect you to pay much attention to this slide, but they're all over the place. So just to give you an insight into what we do in the Marsden, at the minute, all women with non-mucinous ovarian cancer are offered blood tests to check for inherited BRCA alterations. That's done at the point of diagnosis, it's done with their oncologist, so there's no hanging around waiting to get a genetics appointment. If they don't have an inherited BRCA alteration, their tumour is then tested to see if they've got those acquired alterations, because that will also have implications for their treatment. Anybody with a non-serous ovarian cancer are tested for Lynch syndrome, so we do the tumour testing, and again that's done at the point of their diagnosis. Now, I haven't talked very much about the rare non-epithelial ovarian cancers, but all of them basically come to see me to see if we need to think about these rare familial syndromes. At present, we don't test for the moderate or low risk genes. So again, that's not an Irish thing. That's, there's regional variations in who does and doesn't offer testing of those things. We don't yet, because we tend to not change management on the basis of the result. If your BRCA or your Lynch test isn't informative, so if we find, you have a strong family history of ovarian cancer, but we can't answer it with the high-risk tests, we will recommend risk-reducing surgery to people with 2 or more affected relatives with ovarian cancer, and that's, not an easy decision. But ovarian cancer is not the kind of cancer that you want to get, so if you can prevent it, we try to. So in summary, all women with high-grade serous ovarian cancer should definitely be offered BRCA1 and BRCA2 testing, be it through oncology or genetics. Consider Lynch syndrome if there's a non-serous type of ovarian cancer, and if you've got a family history of other Lynch syndrome associated cancers. Consider other inherited risk factors if testing for that is negative. At the minute there won't be testing necessarily available, but you should definitely treat their relatives as if they're at high risk and consider risk reducing surgery in those instances. A couple of useful resources for patients. So if you go to our website, so it's just royalmarsden.nhs.uk, if you navigate to our Cancer Genetics Unit webpage, you will find this booklet is 48 pages long, so it's pretty comprehensive, so it's everything you want to know about BRCA, but we're afraid to ask. And there's also one for Lynch syndrome as well, which is really useful. I've also developed this Cancer Genetics website, and the lovely Michael O'Leary in Galway shows me how to use an iPad, so you can have a little look at there's videos there about risk-reducing surgery, there's videos about PARP inhibitors and how they work, and there's videos about what you can do to minimise your risk of ovarian cancer as well. So I think hopefully people find them useful. Thanks a million to Sharon for inviting me today, and of course for OvaCare for the invitation. Thanks a million.